So I thought I'll start with tetralogy of Fallow, as we know is the commonest congenital heart disease. So when it comes to breakthroughs, there is no major breakthrough in the surgical procedures. You know, the surgical technique, there is nothing much. But rapid progress has happened in the interventional procedures like palliation and the correction of congenital heart diseases as early in life. An increase in the expertise of protocols to evaluate congenital heart diseases even antenatally, post-operative care and long-term follow-up to improve the longevity and quality of life. So that is what has happened in the last few decades. Now, history of management for patients with tetralogy represents almost the entire evolution of management of almost all congenital heart diseases. It's one of the commonest cyanotic heart disease, constituting about 75% of all the cyanotic patients. Now, you know the four parts of the tetralogy, which is ventricular septal defect, infundibulopulmonary stenosis. Now, these are the two main things. And the infundibulopulmonary stenosis causes right ventricular hypertrophy, and also there is overriding of aorta. Overriding of aorta, what does it override? It overrides the VSD. That's what is the tetralogy of Fallow. So it's the same thing now. Now, the treatment parts, you know, as we used to have palliative shunts. You know, we used to do classical Blalock-Taussig shunt as early as 1945. And the first complete correction was done in 1954 using mother as the bypass machine. And since then, we have had valved conduits introduced in 1964. The modified Blalock-Taussig shunt, where we put a graft between one of the subclavian arteries and one of the pulmonary arteries, was started somewhere in 1982 at Great Ormond Street Hospital, which is where I trained for some time. From the 60s to the 80s, there's been marked improvement in survival of intracardiac repairs. Progressive decrease in the age of primary repair to almost the first few months of life is what is now practiced all over the world with fairly good results. Now, if you left the tetralogy without treatment, what would happen? The 1-year survival is about 66%, the 2-year survival will be around 49%, and to 20-year survival will be only about 10 to 15%. It is because of the physiological problems that we face due to the anatomical problems. There is severe cyanosis, the hemoglobin is very high, platelet counts are abnormal, so these kids are more prone for cerebral strokes, renal failures, and multi-organ failures as age progresses related to cyanosis and its complications. Now, the investigation part, echocardiography is the primary tool for imaging TOF. Contrast-enhanced CT angiography of the chest, more widely accepted in the current era if you want to see the branch pulmonary arteries. Cardiac catheterization has got a role, but it's getting more and more limited because we get all the information that we need by echo and if needed by CT pulmonary angiogram. The only reason I say it's got a limited role is that it gives definitely information, but then, you know, cardiac catheterization is such an invasive procedure, and these kids who have got severe cyanosis could go into spells during procedure. So, you know, it adds to a little more of morbidity. But still, if you have tetralogy with other complex congenital heart diseases or things that are not very clear even in a very detailed echo, cardiac catheterization still has got a role. Now, the gold standard for diagnosis is the Z-score. The Z-score of measurement is the number of standard deviations of a value from the mean value at a particular body surface area. In other words, a Z-score of 0 corresponds to measurement equal to the population mean. That should be the normal for an ideal population. Now, the Z-score is primarily for assessing the size of the branch pulmonary arteries. If the size of the branch pulmonary arteries are within the Z-score range of a particular body surface area, however small the child is, irrespective of the age, weight, we could still go ahead in today's world for a complete correction of tetralogy. So the range of Z-score is from -2 to +2. Any value below -2 is considered to be very small hypoplastic pulmonary arteries. In those cases, if you go and did a complete correction, because the pulmonary arteries are small, these kids will develop RV failure. And the same way, if it is more than -4 or -5, they are definitely hypoplastic and they will only need palliative procedures. Now, Z-score of -4 or more or higher indicates very dilated aneurysmal branch pulmonary arteries, which we see in absent pulmonary valve syndrome, where there are hugely dilated pulmonary arteries because of the severe PR, and there is possibilities of compression of the bronchi, producing recurrent pneumonias, collapse, and bronchomalasias. So measurement of Z-score has made it very easy for easy feasibility of complete intracardiac repairs versus palliative procedures. The CT angio is less invasive, but it's an excellent assessment tool on the basis of its superior imaging of the RV outflow tract, size of the pulmonary arteries, collaterals, and coronary abnormalities. And the newer software have got the ability to reconstruct the entire image in 3D. So you can see the pulmonary arteries from the front, from the back, from the top, in whatever way you want to. It can be sliced and gives a better appreciation of the anatomy that you're going to face in theater. Now this is a CT angio, and this shows the branch pulmonary arteries very clearly that you can see there. And now this is again a CT pulmonary angiogram which shows the MPA and the branch pulmonary arteries. Now cardiac catheterization is more invasive, precipitates cyanotic spells. It's not in a simple, straightforward tetralogy of Fallow. If you only have RV dysfunction or LV dysfunction and we want to know the end diastolic pressures and all that, that is where a cardiac cath will be helpful. Just to delineate the anatomy, I think echo is the number one modality, and the number two is, if possible, a CT pulmonary angiogram. Now, chest X-ray, we all know, the typical boot-shaped heart that we see in all tetralogies. Now, the timing of operation. Now, there used to be an older concept that kids should be 1 year of age and 10 kilograms. It's some kind of a magic number, 10 kilograms and 10 months or 1 year of age. It is no more like that. From there, we have come down to say 3 to 6 months of age and even 6 kilograms. Now, but having said that, the lowest weight that we have done in our hospital is around 4 kilograms. That is the present concept. The idea is that we don't want the children to be exposed to cyanosis or hypoxia for an extended period of time. It is not good for the brain. It's not good for the entire development of the child. So we do it as soon as possible, provided the anatomy is feasible. As I said, if the Z-score is within the normal range, we still go ahead, because age or weight does not matter in today's world. For any pediatric cardiac surgical procedure, it can be done safely. Now, the only thing is, in a private setup, if you did a tetralogy of Fallow in the first month of life or the second month of life, it is just that they will probably stay in the ICU for a longer period of time. And as we are all very cost effective and very, very conscious about the finances, so only because of that, we may be restricted in doing tetralogies in newborns, the first 2-3 months of life. But generally, by third month of life, now majority of the centers in the world are doing complete corrections of tetralogies, provided the anatomy is feasible. Okay. Now, currently, the trend is to perform surgical procedures before the age of 1 year and preferably by the age of 2 years. Majority of patients born with tetralogy now thrive very well into adult years. Now, the contraindications for a primary repair is when you have very low birth weight, recurrent cyanotic spells, very small pulmonary arteries, associated problems like multiple VSDs, or these are the reasons where we cannot do a complete correction. There we do a palliative shunt, which is connecting one of the systemic artery to the pulmonary artery, one of the branches of the subclavian artery to the pulmonary artery. So the initial was, the classical BT shunt, where we used to tie off the subclavian artery and directly connect it to the pulmonary artery. But nowadays, what you see on the left side is you interpose a graft so that the blood supply to the limb is also not compromised. Because, when you did a classical BT shunt, the incidence of limb ischemia on that particular side was very high. And if you're a right-handed person and the kids had claudication while writing and all that. So that is why this concept of using a graft has come into existence. We use a PTFE graft, polytetrafluoroethylene graft. The only thing is that these grafts tend to get blocked. So they need to be kept open by giving aspirin at the dose of, say, around 5 milligrams per kg body weight. And that should be continued till the next operation. Now, Apart from this, in a modified BT shunt, we also try to avoid dehydration, excessive sweating, fever, vomiting, diarrhea. All these need to be sorted out and treated as quickly as possible. Because once the child gets used to a little higher oxygen concentration, if the shunt gets blocked, they don't like it. The body does not accept it. They don't accept the levels that they had before surgery. So they decompensate, and we have had many times that kids even die before they could reach the hospital if they have a blocked shunt following an episode of acute gastroenteritis. Now, primary repair, the advantages is it avoids the risk of palliation, prevention of, whatever you do on the shunt, it causes some kind of a distortion of the pulmonary artery. So all that can be avoided. Avoid the need to do another operation and prevent unnecessary RV dysfunction. These are all the reasons why we want to do, and more importantly, to prevent unnecessary exposure to hypoxia for extended periods of time. So the complete correction is basically closing the VSD and relieving the pulmonary infundibular stenosis. By closing the VSD, the overriding gets corrected by itself, and the right ventricular hypertrophy will regress with time as soon as you release the pulmonary stenosis. Another present thing is that we always leave a small patent foramen ovale in all tetralogies. This helps in the immediate this is a newer thing. It helps in the immediate post-operative period, where if there is RV dysfunction because of muscle resection, this PFO will act as a vent and decompress into the left side. So the offset is that the saturation may be a little less. It may be high 80s or low 90s, but still the post-operative period is very smooth. And most of the times the PFO doesn't need to be done anything, but if at all it causes too much left to right shunt later, the cardiologist can always plug it with a device. So post-operative complications, what we normally see is RV dysfunction and RV failure, but that is all now overcome because we know how much to excise and always leave a PFO, and we don't put big patches across the RVOT because it causes very severe pulmonary regurgitation. Apart from that, infection, bleeding, and heart blocks, which are common to every surgeries. Late problems are because of severe pulmonary valve regurgitation, which can cause RV failure. So there are some indications where we have to go and put in a valve, but even there, the recent advances is that we can put in a percutaneous valve percutaneous pulmonary valve in the right ventricular outflow tract, and that can take off all the stress related to a reoperation. So this is the last one I just wanted to say. Tetralogy is such a disease that you correct and give oxygen to the body. They do remarkably well. Now, this child, which is in the picture, is a 7-year-old boy who came from Nigeria. He came all the way from Nigeria, and he came to the Apollo emergency, and he arrested. So we brought him up, resuscitated him, and I thought because he arrested, maybe we could do just a BT shunt and improve his oxygenation and get him better. So we took him for a Blalock-Taussig shunt. We did a right-sided shunt. But I think, the amount of oxygenation which improved after the shunt was not enough for the body. So we brought him back to the ICU, and again he arrested. So I can tell you this child was massaged for nearly one hour. When we got the theater ready, we took him back. So, the shunt was working, but still the child is arresting, so we didn't know what to do. So we thought at least we'll put the child on the heart-lung machine and give some support to the body, give better oxygenation, and rest to the heart. So we put him on bypass. And then we redid an echo, or we saw the heart from outside directly, because a shunt is done from the thoracotomy, but this was from the sternotomy. The anatomy looked more or less okay. So we took down the shunt, and I closed the VSD and did a complete correction of the tetralogy of Fallow. This boy was not waking up for 3 or 4 days. But then by the 5th post-operative day, he woke up. Another thing is he also came with the left-sided hemiplegia. So almost the left-sided hemiplegia also recovered partially, and he woke up. There was no other major, problems related to the brain. And he went home very happily. And now I'm told that it is now 10 years since I've done the surgery. He's able to walk. His speech is okay. So what I'm trying to say is tetralogy of Fallow, timely correction is a very rewarding operation. And we see patients living into adult life with a near normal adult life. Thank you very much for your attention.
Thank you, Dr. Buthu, and maybe have a small 1 minute or 2 minutes of any interaction or any comment from Dr. Manisha or anybody else here. I think justice has been done to the talks